Hello, everyone. We'll just get gathered here, admitting everyone. Looks like I'm admitting everyone. So I'm Rick Blackwell, I'm the Director of Government Relations for Oregon for Pacific Source. I'm also on the board of CCO Oregon. Definitely appreciate everyone showing up. Oops. So if you don't mind exercising the chat, putting your name, title, and organization in the chat so we can see who's here as you join and have a moment, that'd be great. Give it just a minute here, Jeremy, and then we'll get started, I think. All right, I think we're slowing down a little bit. So thanks again, everyone, and welcome to the concurrent session, the breakout session on what do we mean by a global budget. I'm certainly looking forward to learning myself what a global budget is. I should probably know by now. Again, I'm Rick Blackwell. I'm with Pacific Source. Jeremy Vandehey has graciously agreed to join us for this session. Just a couple housekeeping notes for everyone. We are recording. I think everyone knows that by now. For Zoom controls, I think the ones that I want to emphasize for sure. If you want, I'll monitor the chat to see if anyone has any questions when we get to that part of the session. So please feel free to drop a question in the chat box. If you want to raise your hand and speak instead, go ahead and use the reactions tab and raise your hand. When you're done, please lower your hand so I can make sure that I've got everyone to the extent I can. So thanks again for that. For this session, we're going to be talking about the 1115 demonstration waiver. This is really the kind of the negotiation, starting point of negotiation between the state and the Centers for Medicaid and Medicare Services to create the next 5-year plan that will start in 2023. In particular, for this section of the breakout sessions, we want to talk about moving towards a true global budget. A global budget will increase spending flexibility and coordinated care to help our delivery system offer care and services in the most patient-centered and community-led way. Certainly, the state has made strides towards global budgeting since the start of the CCO experiment in 2012, but a waiver from CMS to move further in this direction would help us ensure care coordination through various transitions of care, allow CCOs to further support community-based work, improve accounting as we move towards value-based payment, and maintain accountability on the system to hold a growth rate of less than 3.4%. Certainly a lot of details to figure out in getting there, and we still have to negotiate with CMS, which may impact what we call global budgets. And in particular, as we heard this morning, the way that the agency would like to discuss refining the budgets, I think is really of interest to me. So Jeremy, I'll just go ahead and turn it over to you if you want to introduce yourself and have about 5-minute kickoff. And please, just as a reminder, let's all have everyone on mute as we start. Thank you.
Thanks, Rick. For those of you who don't know me, Jeremy Vandehey, I'm the director of the Health Policy and Analytics Division within OHA, and one of the folks within OHA that's been working on the vision for our future 15 waiver and Medicaid. Let me give a little bit of background and kind of why we're talking about this issue, why we think it's important, and we'll leave most of the time for questions and discussion. Taking a step back, in 2012, Oregon launched this new coordinated care model for Medicaid with the idea of embracing a couple of key principles. Up to that point, We've really struggled as a state to get costs under control. We've really struggled to have the health system be really focused on improving quality and outcomes, and facing a pretty significant budget challenge. We knew that our traditional levers for balancing the budget would only shift costs around the system. Usually we balance the budget in tough times by either cutting benefits or cutting eligibility or cutting provider rates. And unfortunately, that garners some short-term savings, but ultimately people are going to end up in the emergency room. They're going to have health issues that exacerbate, and we're going to ultimately pay the cost of that. So taking a step back, decided as a state to really create a sort of fourth path on how to manage the health system. And thinking about that, embraced a couple of things. One, healthcare costs were growing far too fast, 6, 7, 8% per person some years, and much faster than the economy and the state budget. So that problem number one. Problem number two, we know, and there's been a great body of evidence nationally that there's a tremendous amount of spending in the health system that actually is waste or doesn't actually improve health. And we spend about twice as much as a country per person on healthcare as other wealthy nations, and don't have better outcomes. And there's estimates that about 30% of what is spent on healthcare doesn't actually improve health. And it's no one single thing. It's just sort of a lot of inefficiency across the system. And the third issue was that we also know that about 85% of what impacts somebody being healthy, which is the end goal here, is actually outside the medical system. It's making sure folks have education and food and transportation and housing and all of the other things that go into folks being well and healthy. So taking those things together, created a new model that was really designed to fundamentally change the economics of the healthcare system on the ground, and to really create a new model where we created community accountability for managing the health system within a budget. And the idea was that would really drive efficiency in a way that would actually improve health outcomes and lower costs. A big component of that was to build a new thing called the global budget with CCOs, and to fundamentally change how we pay the healthcare system from the state down to the community. And there were sort of two components of global budgets. First was to blend the various healthcare funding streams into one payment to these new coordinated care organizations. Previously, we paid different organizations for physical healthcare, oral healthcare, and mental healthcare, and members had 3 different cards in the pocket. And the problem with that is it created a disincentive for different parts of the healthcare system to work together to manage people's health. The second piece of it was really to fundamentally change the dynamics of how we pay the healthcare system to look and feel like it was a budget that the healthcare system had to manage to. And what I really mean by that is to change the financial rewards within the system so that it incented prevention and upstream investments and frankly paid providers for patients being healthy instead of just sick. As we designed this concept of a global budget, the term global budget has been used in health policy for decades. You can go back. The earliest article I can find is article that Drew Altman, who is head of Kaiser Family Foundation, wrote back in 1993 about the need to move the national healthcare system to a global budget. So this has been percolating out there for a long time. But what you'll usually find in research is folks either talking about it at a very macro level, across the entire state or across the entire national healthcare system, or they talk about it at the provider level, like moving a hospital to a global budget. There aren't a lot of other examples out there. What do we mean by a global budget at sort of the health plan level? And so we have been sort of making this up as we go along here and trying to figure out how do we pay a health plan differently to fundamentally change the system, the economics of the system. And I don't mean to imply that a CCO is just a traditional health plan, but it is the intermediary between the state and providers, and how do you pay that intermediary differently? Looking back on the last 10 years, we've learned a lot. I think on the first change around blending the funding streams, we've been pretty successful. We were able to blend almost all of the Medicaid dollars into a single payment out to the community. There's still a few things that are outside of that. But by and large, we've merged now physical, behavioral, and oral health. I would say, piece of that was to really drive more community decision making, and I think we've made some gains there. But the one thing we haven't seen is we haven't seen major shifts in how those dollars are now going out to providers. The idea wasn't just to blend the funding streams. It really was to blend the funding streams so the community would have a conversation around how do they best make investments to keep people, frankly, out of the hospital, out of emergency rooms. And we haven't seen a lot of major shifts between physical, behavioral, and oral health on the ground, but we have blended the funding streams. The second piece has been more challenging. How do we actually pay the health system in a way that looks and feels like a budget and changes the financial rewards to really reward keeping people healthy and frankly, having providers feel like the way they actually make money is by folks being healthy and not just providing more healthcare services when people are sick. A big struggle that we've had in that has really been the limitations on what our federal partner CMS requires and how we pay CCOs. They've never given us a waiver away from the managed care regs that describe how you have to pay any managed care organization in the state. And what that means is that primarily we have to pay CCOs based off of their recent medical spend. And the reason that's important is because it sort of locks in an incentive to continue to provide healthcare services instead of other types of services, health-related services that could keep somebody healthy and could avoid the need for a healthcare service. We've done a lot of different things over the last 10 years to try to change those dynamics and to reward CCOs for being efficient and for keeping people healthy. We've found a mechanism for CCOs to be able to track and in essence be reimbursed in future years for something called health-related services, which is a non-medical service that improves health. We've launched a variable profit margin to try to reward those CCOs that are keeping costs down. We've moved to a 2-year rate and to try to, with an adjustment in between, the idea is to try to allow for more of a longer period of return on investment and try to promote more dollars upstream and into prevention and primary care and other places. The struggle, though, is that it's also gotten more and more complicated. We've found all these little levers to try to say, okay, if you provide this non-medical thing, here's how you'll see those dollars show back up in some future year. And we think we haven't actually fundamentally changed the economics of this system. We think we've been extremely creative, and our actuarial team has been, I think, the most innovative of any team in the country. But we don't think we've really fundamentally changed the economics to promote population health. And a good example of that, unfortunately, is the heat event this summer that resulted in, as folks know, really unfortunate number of deaths. And what we didn't see the type of proactive outreach that I think we would have expected under a true global budget for the healthcare community to see that there was an event coming and that they should want to go out and actually do that initial outreach and prevention and provide air conditioners. We've I think worked really collaboratively with CCOs to correct some of that and come up with some more expectations, but unfortunately it was an example that the system hasn't really moved to true population health. And part of that we think is that has been the limitations on how we actually pay the healthcare system. Is it's still easier, unfortunately, to provide the healthcare service after somebody's sick than it is to provide the thing that would have kept somebody healthy. So in our next waiver, we're going to swing for the fences. We're really feel like this is the time with this administration and 10 years of experience under our belt to really think about what would a true value-based global budget look like, and how is that different than how we've talked about it in the past, and how would we actually build and manage that. Our overall vision is basically that, and I'll premise this with we have not talked with CMS, our federal partners, about any of this in any detail. We're still very early in the process and really don't know what their reaction will be. But they are talking about things like value-based global budgets at the national level, and so we feel like there's a good opportunity here. So our vision of what this would look like going forward is that we would build a base budget. We would look back at over the last several years of healthcare spending, would look out as many as 5 years, while also considering recent trends like COVID, but feel like, we now have a number of years since the Affordable Care Act went into place, that we have experience and we should be able to build a budget that we have confidence covers the services that are on the Oregon Health Plan, and then trend that forward for a 5-year period over the course of the CCO's 5-year contract, with the idea that it would grow at our cost growth target that we've set as a state. We've set a 3.4% per person healthcare cost target across all state programs, and that this budget would grow on a per capita basis at that level. That's different than now, because right now we have to go in and readjust the budgets every single year. And in this scenario, we would not be doing any automatic readjustments. We would be monitoring very aggressively. We'd be monitoring consumer protections. We'd be monitoring quality and access, what's happening with finances in the system, making sure that CCOs aren't going out of business. We'd be monitoring for something unexpected happening that maybe would make staying within that growth target unfeasible, like a new treatment or a pandemic, and would have a mechanism to go in and make an adjustment if we needed, but it wouldn't be automatic. The expectation would be a CCO basically has a per capita budget, and it grows at a sustainable rate of growth for 5 years. We think this would actually allow our actuarial team would not go away. We actually think this would free them up to do more monitoring of what's happening with cost and quality on the ground, what's happening with access, what's happening with members' experience and outcomes. And we'd have protections where we could jump in if things were not going as expected. The overall goal here, like I said, is to have this really look and feel like a budget that the community needs to manage to, and that in doing so, the health system and community would see that really how you manage to a budget is by managing population health. The healthier the population, lower costs, and the easier it is to stick to that budget. The other pieces that would we think would really make things simpler and make it easier for providers to understand what they could provide, and not be so caught up in the details of is this a health related service and does it count, and how do I apply, and how does the CCO get reimbursed later for it, and would get rid of a lot of that complexity. So that's our overall vision. Like I said, we're early in the process. Our waiver expires next summer. We're in the process of finalizing concept papers, including one on global budget. We expect to submit those to CMS in November. Don't expect that we'll really get a read on where they're at and their thoughts on this probably until after we submit our application early next year, and start engaging in earnest with them in discussions. So, Rick, back to you.
Jeremy, thank you for that. That was quite a lot to unpack there, but very important to make sure we covered the overview. I want to make sure I leave time for folks to ask questions, but I did want to start the conversation with one related to the health related services. So, we heard, I think, from Governor and agency staff today that trying to figure out how to include social determinants in the medical spend. But currently those aren't rate categories in of themselves. So how would these kinds of these spend be included in a global budget, particularly over time?
So this gets a little bit in the weeds, but most basic way I can sort of describe this is under current regulations, CMS makes us build a capitation rate, the current global budget to CCOs, with two major components. One is a medical portion that's designed to make sure that we're paying a managed care organization enough to cover all of the covered services, all of the services that are on the prioritized list. And then an administrative portion that's aimed at covering the administrative costs of the CCO to operate. When building the medical portion, we're really only allowed to look at what CCOs have spent in the past on healthcare services. And we've been trying very hard over the last 10 years to have CMS allow us to count both what they're spending on medical and what they're spending on social determinants of health. In our last waiver, we were allowed to create a sort of new, somewhat new third category of health-related services, which would be non-medical things, things that aren't on the prioritized list, but improve health. And we're able to start tracking those, and we're able to count those for as medical expenses for the medical loss ratio, but weren't allowed to count them in the medical portion of CCO's rates. And so what that has allowed, we think, is it's created the pathway for CCOs to provide health related services. It's created the pathway for them to get those dollars in future years. But what it hasn't done is it hasn't truly offset medical costs. And so if you're a CCO and you're looking at and I'm not saying that this is exactly what folks do behind closed doors, but we think this is sort of just a sort of how the system functions, is that it is still easier to provide more medical services, and there's still a risk that if you are really efficient and you're reducing medical services, that you'll see the medical portion of your budget decrease in future years. Now we've tried to create some mechanisms to prevent that from happening. But as I mentioned, they're fairly complicated. In future years, what we'd like to be able to do under this new global budget is count health-related services. When we build that first budget, we would count both experience on medical spend as well as health-related services. So whatever CCOs have been spending up to date, that would be included in building the base budget. From there, there would be no annual rebuild of the budget. So the budget's the budget for the next 5 years, whether you're spending it on medical or you're spending it on health-related services. Now, CCOs would still need to track that, because at some point we'll need to come back and rebuild that budget 5 years from now. But we hope that would get out of the really short term, each year needing to figure out what was spent to be able to make sure that it gets counted in next year's rate. So it still would need to be tracked. It still would need to be monitored. But we think it would make it easier for CCOs to see that if they are spending efficiently and they're reducing costs, that they've got a budget that they know is going to be basically guaranteed for the next several years.
Thank you for that. Any reactions to that, folks in the crowd? Just want to make sure I'm getting some engagement here. It's okay. I think, we're all kind of policy nerds, so the weeds are just fine. Oh, George, go ahead. Please answer your question.
Yeah, I'm from Jackson Care Connect on the CAC board side of things, and we are doing a lot of work on the front lines. The thing that is being discovered on some of us members would be that in order with this global budget thing, I've heard from members that if the providers wouldn't charge so much, it could help in the global market when this waiver comes out for next year to lower the cost. They're thinking that the providers are charging too much and don't understand why. That's probably why there is this CCO getting these incentives and being charged high numbers in order to do their matrix. If you're understanding what I'm trying to say.
I do, George. Thanks for the question. I'm totally tracking, and I agree with you. I think you really highlighted the challenge, and when I talk about changing the economics, really what we mean by that. Providers in the healthcare system right now are largely paid based off of two things: price, what's the price they charge for a service, and utilization, how many of those services are they providing. And in the current way that we have to build capitation rates, we basically have to add up all that healthcare spend in the previous year, and how much is spent is dependent on those two same things: utilization, how many services were provided, and what was the price. And there's still basically in order to try to maximize how much you get paid next year, there's still an incentive to increase prices and to increase the number of services that are provided. And so moving to a value-based global budget, what we want to see on the ground is we want to see the provider community, the CCO, consumer community come together and say, we've got a budget, it's set, it's growing at a rate of growth that we think is sustainable, but we've got to figure out how to manage within that budget. And that means that we need to figure out how we're paying providers differently. We need to figure out how we're paying them an amount that operates within that budget.
George, let me just see if there's any other questions first before I let you do a follow-up. Doesn't look like there is. Go ahead, let's do a brief follow-up, and then I want to pivot to some other areas.
Okay, my next question, and to be the last one that I know of. With the providers charging too much, can the legislature work with OHA and you guys to make sure that things are not, or at least CCOs to make sure that prices don't go up from providers?
Yeah, thanks, George. I mean, I think if we're able to get the vision that we like for a global budget, we think that will solve that challenge. If we aren't able to, and we are able to make some incremental progress, then looking at prices is still a thing that we're going to need to monitor and figure out what mechanisms are out there to keep costs under control if they're growing higher than our target rate of growth. I will say though that part of the reason for the global budget wasn't just about managing prices or managing costs. It was also to drive conversations locally around where should we be spending in healthcare. And so to give you a specific example, it actually might mean increasing prices in some places, might be increasing the amount paying providers. If that's prevention, if that's keeping people, avoiding acute episodes, keeping people out of the hospital, out of the emergency room. So it might mean that we want to see shifts, or we expect to see shifts to more spending in high value patient-centered primary care, or in community behavioral health that keeps people healthy and in the community. So it's not just about managing prices; it's also about really driving those community decisions around where should we be spending this global budget in a community to make sure that it's really improving health of the community. I see a question here, Rick. You want me to jump in on what does this mean for providers? Rick, you might be frozen actually, or I'm frozen and I can't tell. Well, I will jump in on what's the question for providers. I think this would vary. I think in some places this probably would lead to more value-based payment arrangements, more payments to providers that are not based on just fee for service and quantity of services. The other thing that we would really hope though is it would drive more conversations around health related services, around non-medical services, and frankly, hopefully paying the system and paying providers in a more flexible way to get what their patients need. Right now, it's a pretty we hear it's a pretty confusing process for folks to be able to apply to a CCO to get a health related service. This I don't think entirely solves that, but we would hope would drive more conversations locally around what are the best health related services that need to be provided in the community. If that's housing supports as an example, then how do they get those out to the community in a more streamlined fashion so providers know what's available. Looks like we've lost Rick, so I guess I'm moderator and speaker, unfortunately, but I might pause and see if folks have other questions. I see a question from John Duke on health-related services and housing. So if we are able to get the global budget that we'd like, we think this probably solves this issue. But we've sort of got a backup strategy of also looking to set a defined set of packages of health-related services related to housing, and really explicitly say which housing supports could be counted as health-related services. There's a couple other states that are trying to do a similar type of thing, and the idea would be make it easier for community providers, not just healthcare providers, but housing providers and others to know what services CMS considers to be countable health-related services for housing. So we're working on a package of that. Again, if we're able to get sort of a global budget, this is probably more just sort of guidance. If we aren't able to get the global budget that we'd really like, then this might be one of the things that we do to try to make it easier for folks to access housing health-related services within the way we still have to do rates today. The question around our health-related services and medical costs treated equally. Today, no, because you have to first build the amount that you're going to pay a CCO to cover medical costs. And then you have to pay an admin, build in an admin amount that's above that, that's sort of within what the state can afford. And so, and health-related services have to be counted in that admin portion. And we also have a medical loss ratio, meaning that We have to track and make sure that CCOs are actually spending dollars on members, and so when you add all that together, what basically happens is there's sort of a built-in limit on how much health-related services can be counted, because they're just a portion of that admin that's added on the top of the rate. So they're not quite counted equally, which has been the challenge. Matt, I'm reading your question, but can I just put you on the spot to ask it, since I'm not the only one talking?
Of course, Jeremy. Hearing and not want to hold you to the words, because I think terms of art, can sometimes run astray of what we may mean at this point, absent a CMS input yet. But as we think of a value-based global budget in terms of kind of where we want to go compared to where we are and have been, how is the OHA, or how are we as a state looking at the balance of a value-based global budget, from the payer perspective, CMS to OHA to CCOs, and against the additional policy aim of moving providers into and along the value-based payment / care delivery continuum, sort of in mind of the HCP land framework. I'm just curious how the OHA and the state is looking at the balance of those two worlds, because they both involve two-sided risk in effect. A global budget, let alone a value-based one, is in effect capitation on steroids. But how do we do that in a way that to the providers, to the systems that are serving the patients, both in the traditional medical services and non-traditional health-related service modes, how do we balance those two together so that it has vitality and sustainability to the care delivery system and providers, not just the payers? I think there's the top down, what works, versus the bottom up, what works, and trying to think of how those things come together in a way that we don't defeat one in achieving the other and thereby kind of cannibalize our aims.
Yeah, thanks, Matt. If I'm understanding your question correctly, I think what we want is value-based payment, to pay the healthcare system in a value-based way from the top to bottom. So from the dollars coming from the federal government to the state, from the state out to CCOs, and from CCOs out to providers. We've been pushing pretty hard on moving to value-based payment at the provider level. And in our 2012 waiver, I'd argue we had basically a value-based payment arrangement with the federal government. They paid us a large portion of our Medicaid budget based off of meeting certain cost and quality targets. It's been in the middle that's been a little bit more of a challenge, and so we'd like to see it across the continuum. Ideally, if we really are able to get to a value-based budget at the CCO level, CCOs are then having complementary payment arrangements with providers that sync up with that really help them manage to that total cost of care, that help them manage to those quality and outcome measures that we're going to be tracking. One of the things that I didn't touch on earlier, but is an important part of this, is we would also be looking to redesign the quality metrics program. Right now, we pay CCOs about 4% of their global budget based off meeting certain quality targets. It's been hugely successful. We think it's been really one of the pieces of magic, or sort of secret sauce, that have been the magic in CCO's success for the last 10 years. And what we've really heard is that it really drives providers on focus. We've got 12 measures. This is the focus. This next year is these 12 measures. Going forward, what we'd like to be able to do is really have that be equity centered, and to focus on a small set of really equity focused measures, and the rest of the quality measures really to standardize, and that we would be measuring throughout the different ways that we're measuring CCOs, a sort of standard set of quality metrics that CMS holds us accountable, that we would then hold CCOs accountable for, but would push on the quality pool aspect of it would really be equity focused and more upstream. So if we are able to standardize some of those quality metrics and have them be consistent, we think those would then get fed into value-based payment arrangements and help simplify and align things for providers as well. I'm not sure if I totally answered your question, Matt.
No, you definitely hit on probably the thrust of it, Jeremy. I think the other side would be, knowing the complexity of that. Having it's not a CCO alone, but any example in the insurance continuum of sort of being that facilitator of value-based payment, the overseer, the fiduciary of that kind of degree of global budget. Would ASU and actuarial services, to your comment at the onset about freeing up time, would then the deployment of their, time and resource into new arenas be kind of in those aims of not just a overseer, but an assister, a technical bank to kind of help the system not manage their dollar, but, make sure that it is equitable, to where it needs to be. And that, the two ends of the coin, or two sides of the equation rather, balance, and that you don't want to put the providers into an impossible position, that may look simple, but how do you challenge the providers in a way that's equitable for them and also has, vitality to them beyond just, that one contract. So would that be how the state would look to support the system rather than just turning over the expectation?
Yeah, I mean, there's two pieces of this. I mean, I think you're getting one is how we're actually ensuring we're getting the outcomes we want, and that there aren't adverse consequences or unexpected consequences. And then the second piece is, I think, more of the technical assistance. So I think both are part of the model now, and I think would both continue. But we would we think moving in this direction, we'd have one more robust, coherent accountability strategy for holding the health system accountable. Right now, we build CCO rates in one part of the healthcare system. We've got a quality pool in a different part. We've got sort of compliance in a different part. And really, I want to move to what is our standardized set of quality and outcome measures that we're expecting, and move so much of the focus from again, the folks aren't going to go away. They're going to need to be measuring and doing a lot of the more analysis, but each year, but instead of it being for the purpose of continually building a new rate for next year, it really would be around monitoring what's happening with trends, engaging with the health system, trying to understand if there's challenges out there, and if so, what we need to do about it. Looking for opportunities. We would expect that we would start to measure. We would want to measure. I mean, this is a demonstration waiver, so this is a pilot in essence. We would want to be measuring: are we seeing the behavior that we're expecting? And what we mean by that is, are we seeing dollars shift around between different parts of the healthcare system that demonstrates that those community conversations are happening around solving some community health challenges? Would we see, avoidable hospitalizations or emergency room visits go down? Would we see patient satisfaction increase and self-reported health status continue to increase? So we would be doing that type of analysis, and really monitoring is the global budget, changing things the way that we are hoping for.
Thank you.
I'm very sorry for my Zoom crashing out. Have you ever had that nightmare when you were facilitating a meeting and you lost connection? Well, I have now. Anyway, Jeremy, I think there was a question from Terry McLean. Is that right? I want to make sure that we answer that or get that question addressed. Terry, did you have a question? Oh, perhaps not.
Yes, I did.
Oh,
Did
go
you-
ahead. Go ahead, please.
Oh, I was just wondering with the growth for healthcare in general, is OHA going to change or just rethink about the 3.4% growth target that it has? Because actually the growth average is 5.7%, and which is more realistic than the 3.4%, which has been in effect for, I think, since the beginning, for a few years now. So I was just wondering if that was going to be changed at all, or is being looked at to update.
Yeah, thanks, Terry. So we, and I'm not sure if you're aware of this or not, but we had a 3.4% target for Medicaid, which I think you're referring to. We're moving into a model where we're going to have a 3.4% target for the entire health system statewide. So Medicaid, Medicare, commercial. We recognize that's lower than both our historical growth in costs, which has been about 6.5%. It's also lower than all the national projections, which have costs about what you said, 5.5, 5.7 in that range. But the important part of the target has been recognizing that we can't continue to spend 5, 6, 7% per capita on healthcare unless we want healthcare to continue to eat up large portions of the state budget and household income. And so the idea is have this target that helps us get that rate of growth down. Now, I think you raise a really important point, which is how do you then factor in something like COVID and the pandemic? And this is where it's important to recognize that this is a target. It's not a cap. This is not a block grant to states. It's not per capita cap. It's a target that we're shooting for in any given year, and in every part of the system. But recognize there's things that are unforeseen that we don't expect. Nobody was expecting a pandemic, and it's still going to be a while before we see how all that shakes out. And I wholly expect that there's going to be parts of the system where costs are much more than 3.4%. And we'll have to factor that in, and we'll have to have discussions around what the challenges were. And actually, we think having a target provides the value of being able to have a place to have those conversations. What were the challenges that the health system faced over this last year, and recognize that, in any given year, nobody was expecting. I should say nobody was expecting. A lot of people were caught off guard by the hepatitis C treatments and how expensive those were when they came out several years ago, and that was a cost folks weren't expecting. So that those things will always happen. But what we want to do is get that average over the course of time down, and make sure that as a result of the pandemic, we aren't beyond the pandemic still growing at 6-7%. So the target's not going to go away. We are going to have to factor in what happened in the pandemic, and wholly expect that spending is going to have looked different this last year, and we'll have to consider that. Now, when building the CCO budgets going forward, if we're able to get the flexibility we want, we would also absolutely consider what happened throughout the pandemic as part of those trends of building that initial base budget.
Okay, thank you very much. I appreciate that.
And thank you for that question. Jeremy, we have time for maybe 30 seconds on this question in the chat about how the CCO's baseline global budget will be determined.
Yeah, so what we're proposing is that we would look back at over the last 5 years. Right now, CMS regs require that you have to use not more than the last 3 years, and usually we just look at the last year or two. So we would look at the last 5 years, and we think that would give us a confidence level of over the course of time, over the course of things that evolve over several years. Some confidence that is the right amount for the base budget. While we look over the last 5 years, we'd also look at recent trends though, like COVID, and make sure that we're factoring that in. But the idea is look back a little bit farther, and make sure that amount's really is sound, and then have it trend forward for 5 years. So kind of look back 5 years and then a trend forward for 5 years.
In the few minutes we have remaining, any final thoughts, Jeremy, on this idea of the global budget?
Like I said, no other. This is sort of first in the nation. We think we're very well positioned to be able to do this. We've learned a lot over the last 10 years, and if we do this right, we really change the dynamics within the health system to be truly population health focused, and help folks help the community meet the goals we have around health equity as well.
Well, Jeremy, thank you for both kind of pitch facilitating this panel and answering a bunch of questions. And everyone, thank you for asking some really thoughtful questions about the global budget. Really appreciate this. Next is going to be a break until about 11:25, and then we'll have the legislative panel, which you won't want to miss. So everyone, thank you again. Appreciate it.